Hi, I'm Ben.
Hi, I'm Claire, and we're Your Dental Besties, a podcast all about all things dental.
Or not.
Mostly not. Mostly not. So Ben, you had some questions for me this time. You thought you'd do a bit of a role reversal?
I did. I did. Let me just consult my cards and see which one I want to ask you.
Oh, God.
So, this was quite a popular one. I put up a poll on Instagram.
I saw you did this.
Yeah.
I was like, oh, he's copying me.
I needed inspiration. What is the most disgusting thing that's ever happened to you at work?
The most disgusting thing that's ever happened to me at work? Oh, there's one that I don't want to talk about because, yeah, it was pretty gross. But I don't think I should talk about that one. I can tell you something that's funny that happened to me.
Go on, tell us something funny. I'll give you some inspiration for
Oh, yes, so give me some inspiration to see what other people said.
Okay, I'm going to have a little look at my phone. Okay. So, you're going to tell us something funny?
Yeah, so I had a patient once who came in and we were going through like the TPs, and I said to, this is one of those situations where you have to keep your face really, really straight because you have to remain professional. And I said, oh, so which TP do you use? And she was like, oh, well, I use the grey TPs on my front bottom.
Oh, no.
And I reverted back to 12 years old. And and I just literally couldn't. I had to just hold it together. I was like, "Oh, right, okay." And she was insistent that she used it on. I was like, "You mean your bottom teeth?" And she's like, "No, my front bottom." And I was like, "Stop being so insistent."
I hate that when you can't stop laughing and you just vibrating behind your mouth and you're like, "Oh God, please stop." Okay, do you want to hear some disgusting ones?
Yeah, you might inspire me and I might remember something.
Okay, there is quite a lot, and unsurprisingly, there's an awful lot.
I mean, our job is pretty gross.
It gets a lot worse.
Oh.
So, someone said when someone came in after eating a Greg's and said they didn't need to brush, because I would do that.
The amount of times we find tuna and bread. Sandwiches are always the worst. I can't stand it when you see remnants of bread and sandwich.
Tuna packed in.
Or when it's obviously plaque, and then someone says it's because I just ate a sandwich, and it's like no. That there is a difference. It's been there for
days. It's been there for weeks. When a patient pooed all over the chair and refused to go home and clean it up, despite us saying that there was no fee.
Oh my goodness! Really?
Yep. Oh God.
I mean, were they scared shitless? I'm guessing.
Literally. Patient broke their jaw. They were seen in hospital. They came in for general hygiene and they hadn't taken the splint out that had been there for 2 years.
Oh my goodness. They
never removed it.
That has inspired me for one that I can remember. I had a guy who never took his denture out and he'd had it in for years. He literally left it in and thought that is how it's just meant to be. Your denture stays in there and there's no removal. That was disgusting.
God.
Yeah.
One time I was, it was when I newly qualified and I was seeing a patient who had really bad osteoporosis. And she was also deaf. So she came in and she was hunched over. So I had to kneel whilst I was doing a hand scale. Because your lip read and I wore glasses, I took my mask off. So I was scaling away and I was chatting to her. Finished the appointment. She was really happy, helped her out to the waiting room. I was going up the stairs with all of my kit in the box. Mm-hmm. And I licked my lip and I was like, And I was like, shredded wheat. And then I was like, I didn't have shredded wheat for my breakfast. It must have been a bit of debris that had fallen out and had gone on my lip, and I swallowed it.
Absolutely.
Even now, it's scarred me for life, but I'm like, yeah, it's gross.
I'd have had to go and get, I'd be going to occupational health. I'd be getting butter. That's disgusting.
There was still flavour in it, so it's obviously fresh, but yeah.
I'm disgusted, Ben. How am I to concentrate now?
It was gross. Is it starting you to think about disgusting things that you've had?
Oh, well, only the denture one so far. I've never licked something off my lips that have come from someone's mouth.
Oh, God. Do you know what there's been a lot of? And there's been an awful lot, 3 or 4 scrolls, about men getting erections when they're in the chair. Is that a thing?
Well, that was the one I didn't want to discuss with you. Okay, it's nice to know it's not just happening to me.
No, there are a lot of clinicians who have that happen to them.
Yes, yeah. That's the one I didn't want to discuss because it was how do you bring that to conversation? But clearly it's happening all the time.
Yeah, it's a very common thing, apparently.
Right.
Very common.
Yeah.
Which leads us nicely onto your post that you posted
really
the other day.
I did not know you were going to say that as one of the disgusting things that have happened, but I knew what the topic was going to be, and I was thinking, this leads really nicely it's a topic no one just chose this
Very
topic
common,
today.
very common. But clearly, floss or flop.
Floss or flop is what we're going to talk about for our topic today.
Yeah.
So very common for some, but not for all.
Thankfully.
You might be thinking, why on earth is two hygienists talking about erectile dysfunction, which is what we're discussing there, floss or flop, and why flossing your teeth could help improve your sex life? And how do we have that discussion
Bold
with patients?
statement.
Do we have that discussion with patients?
I think we should.
Yeah.
I think we do. It's like choosing the right kind of patient to have that conversation with. I'm not sure if I'd ask someone if they had erectile dysfunction straight off the bat.
I think I would put the information out there in terms of like, I don't know, on the TV in the waiting room or in some sort of like leaflets in the waiting room, let the patient put two and two together and then go, oh, okay, it's really important I see the hygienist. I wouldn't say I necessarily think they need to tell me that they've got erectile dysfunction, but actually it could be a sign of more important things that they need to get checked out. So it is maybe something as healthcare professionals, we should be making them aware. If that's happening to you, you probably need to go and see a GP and get further testing. Did you know 40% of men over the age of 40 have erectile dysfunction and 70%?
40.
40%.
My God, I'm pushing 40.
Are you one of the 40%?
I floss every day.
He flosses, he's not one of them. And then 70% of men over 70. So this is happening a lot. That's a lot of people this is happening to.
70% of men over 70?
Yes.
What, erectile dysfunction or peria?
Erectile dysfunction. So how is it linked is probably what people are asking is that. So when you have systemic chronic circulating inflammatory mediators going around the body all the time, this can cause like a knock-on effect with things like endothelial dysfunction, which we know is the endothelial lining of blood vessels and arteries. If that's not working effectively, it's going to eventually lead to things like blockages and atherosclerosis. So your inflammatory mediators, your cytokines, interleukin-1, interleukin-6, tumor necrosis factor alpha are the main ones that are contributing towards the endothelial dysfunction that leads to the atherosclerosis, that leads to ED. What are the things that are released during chronic periodontitis?
All of those things.
All of those things. So tumor necrosis factor alpha is the most prominent that leads to the sort of the cascade of events that can lead to ED, and that's very much released during periodontitis as well. So when someone's got chronic periodontitis, you've got these circulating inflammatory mediators going around the body all the time, and this happens. This endothelial dysfunction or this atherosclerosis tends to happen in the smaller blood vessels and arteries first, like the vasculature of the penis, and eventually it would lead to the larger arteries. So things like around the heart, or things that can lead to like stroke, for example, so in the brain. So these things, when it happens in the smaller vessels,
that is so high.
It is really high, and if it's starting in the smaller vessels, down the line it can start happening in the bigger vessels. So having that information in your waiting room so patients can see it and realize that if they don't have gum disease, if they don't have this chronic periodontitis, they're lowering the risk of potentially having ED. You're 3.29 times more likely to have erectile dysfunction if you've got chronic periodontitis. And the more severe your periodontitis, the more high risk you are at having ED. And that's all clinically proven. So there is this very big link. In fact, healthcare providers are saying that we should be sending people, or they should be sending people to oral health experts if someone is coming to them with ED, to eliminate one of those as a risk factor, because it's got such a high risk of it being related. So
there's like that bi-directional relationship, like similar to diabetes with erectile dysfunction.
Mm-hmm, mm-hmm. And so they can see positive reactions to people who are having successful treatment. There is very much that link there.
Well, clearly none of them clinicians, they're all doing a very good job with that oral hygiene instruction.
Their patients are flossing like life depends on it, and that's why they're going in like that. So there is this link, and so there is this need there, I guess, to make sure patients are aware that there is a link there. Not necessarily that we have to have the discussion and maybe put it, we don't want to put it on the medical history form. Are you suffering with ED? You probably get a lot of kickback from that. But what you could do is put the information out there, let them see it, and then let them put the two and two together when you tell them you've got chronic periodontitis, and let them go, do you know what? It's really important that I keep seeing you, because in their own mind, they might say this, because actually, if there is a link there, I want to make sure that, one, I either prevent it, or two, that's happening to me. Should I go and see a GP? Should I take this a little bit further? Because with us, it's not just about the mouth, is it? It's not just the mouth, the teeth, the gums. It's the body.
Well, this is something I was going to bring up with you, because There's been a lot of talk on like the Facebook group that we're part of about appointment structure. How do people do everything in that little time? I mean, I'm quite lucky I get 40 minutes for like a normal maintenance, and it's an hour for a new patient appointment.
Yeah.
But you don't want to bombard the patient with all this information. You don't want to be like, you've got gum disease, you've got erectile dysfunction, you're going to die if you don't floss your teeth.
Your heart, your brain, your lungs.
Yeah, everything. But I think instead of it being about treatment focused, I think that the answer is to change the patient's mentality that appointment time is the time with the clinician.
Yeah.
It might just be a discussion, but so long as they understand the reasons for why that is, the patients will be happy. I think everyone fears that the patients are paying, so therefore they need to have something done.
Yeah.
But we pay for the NHS. It doesn't seem like it, but we do through taxes. But you wouldn't go to a cardiologist and they're like, right, we're going to do your heart surgery right now on this table.
Yeah.
Like it's talked about, you understand the risks, it's planned. I think it's the same thing in dentistry, but we're just so fearful that it's this transactional relationship the whole time that it should be about promoting health generally, but the links between oral health and systemic health and why it's really important that they engage.
Yeah, I totally agree with you. I used to be a clinician that used to think I have to get this all out there in one appointment. Like, what if I never see this patient again? They need to understand themselves. They need to understand the disease. They need to understand the treatment needed. They need to understand what they need to do at home. I mean, it's clinically proven as well that a patient will only take 2 pieces of information at best away from that appointment. So,
at best.
At best. Like, so I now am a clinician who says, what is the most important thing that patient needs to take away from that appointment? And I will focus on that in that appointment. So 2 things I think are the most important thing. The need to see me again and why. And what is the tool at home that's going to get them the most biofilm removal? So if they're on a manual toothbrush, it's going to be electric toothbrush. At some point down the line, I need them to see me again, because I'm not going to give them all the answers in one appointment. I need them to know that it's going to be a journey and a process and a lifelong commitment to optimizing oral health. This is why I started calling my treatment oral health optimization, because when it's that sort of transactional scale and polish, like a haircut or like a barber's trim, then you feel like you've got to get it all done in that appointment. But actually, are we coaches or clinicians?
Coaches.
We're coaches. And so we need to, it's not just one appointment and it's all sorted. We need to coach them and make them realize it's a lifelong commitment to optimizing their health, and that it's going to take more than one appointment. It's, the next appointment, I'm going to add on to the information I've given you. And then the next one, I'm going to add on the information. And now from experience, I've got the confidence of knowing that every patient comes back to see me again. The only time they don't is if they're moving to Australia or something like that. I'll let them off. But you're not leaving my appointment without booking your next one. And they always do. I think.
Do you book your own appointments?
Yes. Yeah.
I've started being, maybe last 2 years, I've been booking my own appointments in surgery. It works so much better. I think it's more personal for the patient. They're not going out to reception with a waiting room full of people and be like, I need to come back in 2 weeks.
Yeah.
Like the shame bell comes out.
Yeah.
It's like part of the appointment, right? This is my schedule. This is what days I can do. What days can you do? Trying to marry it up.
Yeah.
Finding a time that kind of suits them, but also making sure that appointment's booked in.
Yeah.
My FDA rate has dropped significantly. Like no one FTAs.
Yeah.
Can't remember the last time I had an FDA, if I'm honest.
Yeah.
Just from booking it in surgery.
Yeah. And I think as well, it then reinforces the fact that you're the clinician making the call that they needed to be seen again at whatever interval that is. And also, like you say, like there is a shame in, like, I need to see this patient again in 2 weeks because it was that bad today. You know, like they don't want to go to reception and sort of have other people hear that. So no, 100% agree with that. But I also, there's a confidence in knowing that every patient sees me again. So I don't have to try and bombard them with information in one appointment. It's going to take time. No one changes all their habits from one session. In fact, if it was as easy as that, every single hygienist would be flossing their teeth every day. And I'm telling you now, I do a lot of teaching, as you do. And I always ask this question. I say, be honest with me. In this room, how many people floss every single day? And it's never a room full of people with their hand in the air. If it was as easy as just knowing it and doing it, everyone would be doing it. I'm a hygienist. I've been a hygienist for 15 years. And I've only started really TPing and using floss every day for the last 2. Right? I'm going to be honest with you.
Serious?
Yeah. Before that, it was 4 times a week.
Oh, so you had the weekends off.
I had weekends off, yeah.
Good behaviour.
Yeah. and that's probably the time when you should be doing it because that's when the chocolate came out. No, I'm only joking. But like I did it a lot, but it wasn't every day. And in the last 2 or 3 years since we've been learning more about systemic health, we've been lecturing a lot more on the circuits about systemic health and how it's all linked to I'm like, okay, I'm not immune from these conditions just because I'm a hygienist. I also need to up my game. And that's taken years of me learning it, understanding it, researching it. So it's going to take our patients time. So pick the 2 of the most important things to do in that appointment. And in the first ever appointment with that patient, it's they need to see you again. They need to like treatment enough that they want to see you again. And what is the one thing that they're going to take away from there that's going to improve their home care? And that's things like changing into an electric toothbrush or modifying the technique with the electric toothbrush. And then eventually, if they're doing that, and that's great, then it's flossing or TPs.
Yeah, I do that. I'll just do one thing. I just say, let's just focus on brushing first.
Yeah.
Because if you go through toothbrush and then you've got TPs or whatever other brand people want to use, and then now you need to floss, it's like, wow, this is a lot that I have to do. It's a complete change. Whereas it's okay, I've got the brushing down now I'm going to introduce the little brushes to make it even better. And you're right, it's a skilled approach, but those patients I think are the long-term habits are formed properly rather than it just being, I'll do what I need to do until you say I'm healthy and then it's all going to go back.
Yeah. And that's the other thing as well, is that it's the slower build, the more likely it is to become a habit and become like a long-term, lifelong habit, instead of it being like, I'll just do a good job every time I come and see you for 2 days and then say I've been flossing every single day. But I was going to say something else there. It's just gone out of my head. You know what I'm like?
I do think because we take indices, so we take bleeding scores, plaque scores, every appointment, I think, again, that's something tangible for the patient. Before, I used to disclose or take bleeding scores like routinely. It was always like, oh yeah, there's a little bit down there or there's a little bit here that you need to focus on. But the patients don't really know what they need to get off because they can't see it. Whereas when you disclose, they can see it and they know, okay, you said it had to be 20%. What am I at now? Like, what do I need to do to improve it even more? So much better.
They're invested in that. The numbers, the stats, they like something tangible, 100%. And I think these are all really good tips for those hygienists out there that are thinking, oh my God, so now you're telling me I have to have a discussion about this as well. No, those discussions with like ED or potentially ED, but definitely discussions with like diabetes, Alzheimer's, all those things come down the line. I wouldn't, in one appointment, the first time I've ever seen a patient, bombard them to the point where I'm talking to them about things like, Alzheimer's and stuff. That comes down the line unless it gets brought up for a specific need in that first appointment. You don't have to structure your appointment to be covering.
I do mention it though. I mention it in the first. I just say, is there a family history of heart disease, Alzheimer's? Link through them all, and then if there is, I think that's quite a good motivational tool for them. If not, then I just say there are risks associated, and evidence is evolving all the time to tell us that.
And then if there's no like immediate risks at that point, further on down the line, I might be bringing it up again to be like, do you know what? It's so, it's great that we've got this far ahead with your oral health and your this much, that the improvements are there, because did you know there's a link with Alzheimer's? Let me explain why, because I've got the time to explain why now. Whereas obviously, if in the first appointment there is that risk factor there, that might be the behavior change motivation factor they needed. And so, you would bring it in at that point. But these are already great discussions. And we're sat here telling people about it. And when we do the women's health courses, obviously the people are going to be like, oh my God, I've got so much to talk about. But like we say, it doesn't have to all be in that first appointment.
No, I think the women's health course is, one, super exciting. Cannot wait to take that around the country. But it's about having an awareness. I think it's a topic, like we've already discussed, it's a topic that's not really talked about, not just in dentistry, but healthcare. And I think it's, again, just broadening your knowledge base so that you might help, even if it's one person in the next 10 years, then at least you've helped that person achieve something that they might have struggled through. And understanding a bit more about the mouth.
And just an interesting thing to sort of touch on there is I was going to go, I found out there's a private medical practice near to one of the new practices that I'm working at. And they've got an ED specialist in there, so an erectile dysfunction specialist. So I was like, I'm going to go in there and do a lunch and learn and teach that guy. He needs to send. Yeah, 100%.
You'll have to let us know how you get on.
I will do. Because he might not realise that, he should be sending people my way. So get into these places and get the referrals from these people would be a really great
That
thing.
was a specialist thing.
I think, yeah. I mean, it's similarly to like women's health. It's part of like men's health, isn't it? So there's like he's like testosterone, and then he does erectile dysfunction. But if you think about it, a guy probably would want to go to someone who is saying, "I deal with this day in day out," rather than maybe go and speak to the GP. So it's probably a little niche area that doctors can.
Well, if 70% have it, or 40% over 40 have it, then it's obviously very popular.
Yeah. Yeah.
No.
There's obviously other reasons, so psychological reasons and things like that as well. We can't say it's all down to
it's
Perrier.
not like you floss your teeth
Every
and then
person has
you're
Perrier.
great. Yeah, no. But it's a really interesting fact, and I think it brings us back to that kind of thing that we're both very passionate about putting the mouth back in the body, working holistically with other healthcare professionals, and just highlighting obviously the importance of good oral health.
Yeah. So we're saving lives when it comes to things like heart disease, Alzheimer's, and we're saving sex lives when it comes to things like erectile dysfunction.
I mean, what's more important, really?
I mean, we're superheroes really in disguise, aren't we, as hygienists?
We are indeed. I've got one last question for you.
Oh my goodness.
And
okay.
it's just a quick one.
Okay.
What one thing could you not live without in surgery?
Ooh.
In surgery, in your own little clinical safe space.
My clinical bubble.
Yeah. What one thing is your like, babe?
Do I have to have one?
One. Because I know you'll have 10.
I've got like 5. Oh, you know what it's going to be, don't you?
Yeah.
It's definitely my EMS master.
Yeah.
It's my EMS master.
It's very, EMS prophylaxis master is mine, number 1.
Yeah. Do you want my number 2?
I want to know if it's the same as mine.
Oh, so have you got number 2 as well? Should we rank them in order? Okay, so my number 2. Oh, my number 2 broke recently.
Is it loops?
Yeah.
Yeah, I can't see. It's the light. Like, I can make out like teeth without them, but I'm much better with them on.
Better clinician with them. When I first, you've got to get over that first week.
When did you start wearing them?
Must be a couple of years ago. Because I've worked for a good few years without them. It was only a couple of years because I was of the mindset like hygienists don't need them. But once I got them, I
think a lot of the students ask like, when's best to get them? Can I get them now? I always say, do like year 1, year 2, get the kind of basic principles, learn to do it without, because if they break and you've only ever done it with them, it's very hard.
That's true.
But then year 3, I think it's probably a good time to start practicing and thinking, okay, I'll get used to it whilst I've got those long appointments.
Yeah.
But then like the light and the actual, what mag do you have?
2.5.
Yeah, mine are only baby. I've got 2. I've got 2.5s and 3.5s.
Yeah.
But 2.5s are great for
hygiene,
routine maintenance.
Yeah, 100%. It's not until you got to get over that first week when you're really dizzy, because I think I was so dizzy in that first week. I was like, I can't deal with this. And I hear that a lot, but you've got to get through that, get past that bit. After that, posture. You know, mine have broke and I've never suffered so much since mine have been broken. So yeah, posture-wise, it's a massive improvement.
Yeah.
You could just see so much more. I'm definitely a better clinician for wearing them. But interestingly, I went to a practice the other day and the dentist at the practice said, I was doing an in-house, and the dentist was like, all the hygienists need to invest in loupes because you can see into the pockets. So all the hygienists were like, they're a lot of money. Like, can you see into pockets with loupes? I was like, no, you can't. They don't give you x-ray vision. I mean, you can see more.
You can. Like, if you wear like 3.5s, you don't necessarily see into the pocket. Like, you're not haven't got X-ray eyes. But when you blow the air, you can see the pocket much
I see. Yeah,
more clearly.
Okay. And maybe that's what he meant then. Because I was a bit like, I wouldn't say you could see into the pocket.
I think they're a really good investment.
They're such a good investment. Definitely worth the money, 100%. So number 3, what's your number 3?
Oh no. I should have said my nurse for number 1.
Oh,
she's going to hate me.
Well, because that should be a given. Like, they are the best thing ever in surgery.
Okay, and the nurse isn't an object.
And she's not an object. She's a human.
Or she.
He or she, exactly.
Yeah, my nurse is maybe number 1, actually.
Yeah.
I've tried like once to work an appointment without.
Do you know why you didn't say number 1 nurse? Because it should be a given that we have a nurse.
Why do we still feel like so privileged and lucky that we've got a nurse?
I'm so lucky I have a nurse. They are the best thing ever.
Okay, nurses excluded, airflow prophylaxis, and then loops, and then...
Oh, I'm going to say saddle stool.
No.
Do you not?
I've tried it. I've bought a special boy one.
I was about to say, is it because you need a
special boy one? Because I tried everything with my back.
Yeah.
It was a split one.
Oh, yes, yeah.
It felt like horrendous.
They are quite wide, so
you've
got your legs wide open with them ones.
Walked like John Wayne for a week. I was like, I'm going to bear it. Yeah. It looked like I just got off the horse when I went to get the patient. And I had it for like 6-7 months. Then obviously COVID happened and then went back, been using it. And in the last month or so, I was like, I'm just going to try a normal chair because my back wasn't getting any better.
Yeah.
I find it much nicer to sit on.
Right, okay.
I just find them really uncomfortable.
What I found really hard is that the dentist would steal my chair when I wasn't working and then adjust it. Because I think I must be on the tall side because they'd adjust it to like, when I sat on it, my like knee would be above my head.
Squat.
I'd be squatting, yeah. So I felt like I had to adjust, and it got to a point where I just stopped adjusting it. So because the whole point is that it's kind of set up to your like hip tilt or whatever. So if it's not set up properly, then it's not.
But I gave up. I'm going to say my camera.
Oh, yes. So what camera have you got?
Just I don't know the brand of it. I think it's Canon.
Yeah.
I got it secondhand with like a flash, like 100mm lens, but it's all set up. So as soon as you kind of want to use it, you just take the cap off, snap, put the cap back on.
Is that the one that automatically goes through to your iPad or your iPhone?
No, not that advanced.
I've got the Smile Light. Have you seen them?
No.
So it's good for getting the light sort of all the way around, yeah. But not that I take pictures anymore. Like I don't have time anymore. Well, at my previous practice before I left, I didn't have time. I've got lots more time now, so I will start getting back into it. I think taking before and after pictures really gets you proud of your work, and it really helps. It makes you excited about what you're doing because you love to see that, like the difference you made.
I look back through them and sometimes at lunch and I'm like, like a little smile on my face thinking like, yeah, I did that.
Because
really good. But it's so good for patient motivation.
Yeah.
Like it's the best.
Yeah.
I think that disclosing, perfect. Like patients just understand.
And we should point out as well, the reason why the EMS Prophylaxis Master is our number one is just because how much more comfortable it is for the patient and the fact that it's efficient. It's designed to be comfortable and ergonomic for the clinician. So it's not just about the patient getting getting a comfortable treatment. It's actually been designed. I don't know if people know this. EMS wanted to design it in order for us to be able to get to like retirement unscathed. So it's good on your hands. It's good on your wrists. It's not heavy. It's all been designed so it's good for clinician, good for patient, and good for practice. When I say I love it, my patients love it, and they love me for it. It makes me sound like makes me a really great clinician because of it. But it's also because it helps me. It helps me to get to retirement without, And
I know obviously we work with EMS, which is maybe something for another podcast, which we can discuss.
Yeah.
But yeah, I think in order to work with them, you have to really believe in it, and we obviously do.
I
the
actually
evidence
only
base.
work with them because I got it and believed in it. Yeah.
So that's our top 3 things to have in surgery.
I think we went through like 5.
Yeah.
Do you want to do agony on call?
Yeah.
I like this bit.
You love agony on and agony on call. I hope my advice is good. I'm not going to get a message after saying, so I was sacked after following your advice.
Oh my God. Well, this one won't get her sacked because she's put, I've been qualified for 3 years and I've tried a few different practices. I'm just finding that the job isn't for me. This is sad. Any ideas on other jobs we can get with a dental therapy degree?
Okay, so I've seen this quite a lot. And I'm just going to disclaimer, a biggest bugbear that I have is that people always comment saying, go into teaching. That is the worst piece of advice ever.
And you would know.
I would know. If you don't love and live that profession day in, day out, teaching will kill you and it'll make you hate it even more.
Right.
You really need to be passionate about it.
Yeah.
Because obviously you've got students who are looking to you for that motivation. If you go into a teaching environment and you hate the job, the last thing you're going to want to do is tell the students, I hate the job, it's awful, da, da, da.
Well, yeah, you're passing that on, aren't you then?
You're passing it on.
Yeah.
I think there are loads of things that you can do. We've got loads of transferable skills. We are excellent communicators. might not be in teeth, but we can communicate really, really well. We're behavioral change experts. There you go.
We're experts in behaviour change, yeah.
Experts
absolutely.
in behaviour change. A lot of our degree is to do with evidence-based. So we're used to kind of read and research. So being like reps in products is a really good job.
Yeah.
Or you can always go back and retrain and do something else. And if you wanted to go back and retrain, nursing or midwifery or
I think it's worth maybe knowing what she doesn't like about it. Because if it's like being patient facing, then you'd be like, okay, well then you don't want a job where you're patient facing. Or if it is it that you're, you know, would you be better off working with children, say, and not necessarily with adults, or the other way around? You've worked with children a lot in the practices you work in. Maybe therapy is not for you. Maybe the hygiene element, focus more on that and try and find. So it might be worth finding out what is.
Sometimes it's sales. So we're trained as kind of health professionals, and then we're going to practice and we're meant to be like ethical salespeople as well, selling treatment plans. I think that can be a huge transition.
Yeah.
But I think it's really tricky.
I think when you're newly qualified as well, that's a really difficult thing to navigate. That's definitely become easier the older I get, and the more I used to feel really downhearted when patients wouldn't take on my advice, or if I was telling them they had gum disease, and I almost felt like I was like, I'm really sorry you've got gum disease. Whereas now I'm like, this is the evidence I'm faced with. You've got the OPT here showing this, or the bite wings that are showing this, and this is what I'm seeing in your mouth, and like it's your disease, not mine, and this is what you need to cure it, and you don't have to have that treatment. And I think that kind of like, I'm not being kind of like, you know, stone cold, obviously, but I'm very much...
you're just presenting the factual information, which I think is really important, but you've also got lots of experience and
it's the experience.
Confidence.
And I think not that you need to stick it out doing something you don't enjoy, but that comes down the line. And when you first qualify, I think especially now when you sort of going on the courses and you're getting taught at university all the things that we should be doing, you know, S3 and everything like that. And then you go into a practice that's very scale and polish mindset.
Here's a 20-minute appointment, no nurse, you've got no equipment, and you've got half an hour for lunch. Get on with it.
That's not for anyone. And if you've gone to job to job to job to job and that's all you've been faced with, then...
I do find courses really help me. Like I've done so much CPD when I first qualified, but... you are in that isolated environment. You go to a course and you're like, maybe it's interesting when you go to a course and you don't know anyone and everyone just sits there quietly. By the end of the course, like everyone's best friends, everyone's chatting. And I think it's like those lunchtime chats where just kind of confirms, actually, it's not just me that feels this. Or, okay, this is just a common issue. How can I get around it? How can I find a solution?
And I think as well, have you noticed in clinic that lunchtimes have been reduced to like 30 minutes? Which I'm actually...
No.
Do you get an hour?
Yeah.
So everywhere that I've seen recently, it's been 30 minutes. I'm not opposed to it, if I'm honest, because I used to get an hour and a half at one practice.
No, that's too long.
Or I used to go to the gym. I used to love that. But
45 minutes, I think, is probably optimal. Like that last 10 minutes of hanging around, I'm like, come on, let's just get on with it.
And now it's just that little bit too much where you're sort of like, I'm actually nearly asleep now and I can't get back into it. Whereas 30 minutes is enough to go. The problem is if you're in a back-to-back 20-minute appointment situation, 30 minutes, you're going into it and you're preparing for the next, like, But I'm finding that lunchtime to getting a lot shorter.
Oh, no, you need to sort that out.
Well, I have. I'm not at work anymore.
Okay. Well, that's the sledgehammer to crack it up, but there you go.
But yeah, I think... and counselling's a good one that she can maybe look into, because that's a lot of what our job's about, isn't it? Psychology. We do a lot of psychology. We don't really give it... Yeah. We go into clinic and a lot of it is counselling our patients and learning how people's behaviours are and how we need to change them. It's a lot of psychology as well.
You learn like a learn-on-the-job apprentice psychologist.
Yeah, basically.
We do learn loads about people and interactions. And
and you have to change how you talk to one person and how you talk
masks,
to another.
Yeah, all the time. Put your happy mask on. Can you put Karen mask on?
Yeah. When someone comes in and you're faced with, I call them a Howard, because that was the patient who will always be fixated in my brain, will be fixed in my brain as the guy who nearly broke me. He basically laid into me once in an appointment, and I was just like, oh my God, like, how do you deal with this? Like, having to deal with conflicts is quite a tricky one, isn't it?
Really hard.
But now I know how to deal with Howards because I've experienced it.
Yeah, you do it once and then you learn so much from that.
Yeah.
Don't you?
So a lot of our job is learning on the job. you can't leave university
because
and
it's
think
fluid all the time. Things change. People are different. You might have a patient that you love seeing, and then they come in, they're like in a real mood with you, or just feel like off, and it's just how you manage that.
That's another podcast episode, how to deal with Howard.
How to deal with Howard.
If you've enjoyed this episode, make sure you share, like, send it to your friends.
Send it, share it, everything.
And if you send your sort of things that you want us to discuss in, it gives us more to give you value-wise. So it's stuff that you want to hear us talk about, information that you want to hear, and we always like to hear from you. It's always nice to get people reach out to us, isn't it?
Absolutely. Bye.
See ya.